Hello and welcome to the Royal College of Pathologists Guideline Implementation Webinar Programme. My name is Peter Johnston and I'm the College Vice President for Workforce and Corporate Engagement. I'm delighted to be hosting this webinar today, where we have leading experts and authors from the latest guidelines for the histopathological reporting of breast disease in surgical excision specimens of breast cancer. The authors will be clarifying with you some of the aspects of the guideline that you may find difficulty with or are puzzling, and will give you practical tips around clinical scenarios to help implement these guidelines. And the authors will be here to answer your questions. Today's webinar, I'm delighted to say, is run in conjunction with the Association of Breast Pathology. And so a special warm welcome to the ABP audience members who are joining us for this webinar. I'm delighted to introduce also the authors of the guideline who will be presenting to you. First of all, Dr. Rahul Deb, and secondly, Professor Sarah Pinder. Just before we start the webinar, I'd just like to tell you that this one is slightly longer than usual and it will last about 40 minutes. Then there'll be questions and answers for 15 thereafter. All the participants, as usual, will be muted. And so if you want to ask a question, please do so using the Q&A function. If you wave the mouse over the screen, it's at the bottom right-hand corner of your screen. And if you could submit your question there, we will collate the questions together from a large audience to ask the panel. So without any further ado, I would just like to kick off by welcoming our speakers. First of all, Rahul, over to you, and thank you.
Thank you. So yes, thank you for the introduction and the opportunity to speak to a wider audience, both with the college and the Association of Breast Pathology. These are some of my declarations, not all relevant to this talk necessarily. So just to give you a little background of what happened. So the college tends to update its guidance once every 3 years, more or less. So the previous version, actually, before I do that bit, even though Sarah and I are speaking here as kind of deputy and chair of the writing group, a whole host of colleagues have contributed to these guidelines, and I need to thank all of them for their contribution. It's quite a significant piece of work, and a lot of personal time and investment, has gone into this. So thank you very much to all of them, and they're listed there on that list. And this, as many of you will know, was released in November 2024. So in terms of background, actually, as I said, every 3 years, the college tends to look at these guidelines. So the previous one was 2016. And around 2019, we were looking to kind of look at the revisions and updates, etc. We actually had a face-to-face meeting. Remember those things that used to happen amongst the authors to decide what bits need looking at, what are the changes we think are good, etc. And then COVID happened. That stalled us quite significantly because obviously other priorities took over in a way for many of us. But also in a way, it gave us an opportunity to what should I say? Teams became normal. So Sarah and I spent many hours, on Teams going through the document literally line by line. And so while there was a problem and it stalled the document, it also helped us kind of come to the end of it in a way and finally released in November 2024. So a quick overview of some of the changes. What we've done here is we've continued the back to basics approach that we saw in the 2016 version, basically dealing with common practical problems. Some of these also more clarity on tumor size, on grading, on LCIS, florid and pleomorphic LCIS. We aligned ourselves with the WHO tumor types and many other and ICCR guidance as well. Some sections were added, but some others were simplified because we felt there was too much detail in it. And we're always the balance between this is not a textbook, this is a guideline, for practical implementation. And obviously on ERPR and HER2 testing. So I'm going to kind of roughly try and deal in the 20 minutes I have on the first 3 bits and then hand over to Sarah who will do the other things. I'm just going to get the time to make sure I don't overrun. This is a more detailed version of the key changes to this document. I also need to thank Clinton Boyd, who's the secretary of the ABP as well. I've pinned some slides of him in this talk. So thanks, Clinton. So in terms of back to basics about fixation. Fixation and mastectomy is still a problem. When some of us are involved in the QA visits in the screening program, and we see that there's still a problem. And so we've given more guidance on fixation. Key being, get the mastectomies into the lab and sliced into as soon as possible. And if possible, with and what is called a cold ischemic time, as in from when the specimen comes out to into formalin of less than an hour. I appreciate geography might determine that that's not always possible, and we suggest that you could potentially train your surgeon by mutual consent to kind of slice into the mastectomy like 3 or 4 cuts maybe, or however you seem fit. I think that even though preferably we don't like the surgeons messing with the specimens because they don't do it well sometimes, that is better than having it unfixed lying over the weekend, late evening list, or etc. If you don't think that's an option, refrigeration can also help. Put them in the fridge overnight within theater and then send them the next morning. When the specimen arrives like this, it really is no good for any of us. Really, we've lost all prognostic predictive information in this tumor, and it doesn't help anyone really. In terms of also radioactivity, I don't think it's such a problem anymore. But we used to get asked about, people are not being allowed when a central lymph node is done. People were asked to keep them in radioactive cabinets and all the rest for 24 hours, 16 hours, etc. There's enough evidence that that is no longer necessary. You don't need to delay the specimens for, even if there's a sentinel node procedure. Lab staff who deal with it don't need to be registered as radiation workers. And obviously, you will have a radiation protection officer who might help you with this. And if you have trouble, just throw these guidelines at them. There are references as well. In terms of dissection, there's not much change in terms of wide local excisions or mastectomy specimens. But we've added a little more clarity in some of the dissection kind of general principles. So for a wide local or a lumpectomy, the margin that's closest to the nipple should be sampled in addition to the radial margins, especially if there's DCIS present or if it's pure DCIS. In skin sparing mastectomy, there's increasing interest in the anterior aspect of the specimen in terms of do we give them radiotherapy or not, etc. So please sample them if it is close and mention it in your report. In a nipple sparing mastectomy, the nipple is a true margin, so that should be sampled. And if it is involved, they will go back and actually remove the nipple because it constitutes a positive margin. And the last point in here, which is very, very important actually, and I think is please provide a blocky in your report. Not just, definitely at least one in terms of the best tumor block or tumor suitable for molecular, etc. But I would suggest have the whole blocky, because when you go back to specimens, it really becomes very difficult if it's hidden away somewhere, if slides get sent away to another center. Just having the report without the blocky really makes it very, very difficult to make any sense of the report. So my suggestion would be include your blocky in your macro description, which is in your printed report. The biggest change in terms of dissection in this document is the addition of this section on additional specimen types. And while we were kind of developing these guidelines, we had a few meetings around the ABP had a meeting. In annual meetings, we kind of stood up and asked people around sessions, what is it that you think we need to include? And this kind of came up number one of the things about confusion out there in terms of how do we process these specimens? The biggest fundamental kind of challenge was that these are all called different things within different departments. So what you might be calling a bed biopsy, or what your surgeons might be calling a bed biopsy in your department, is called a cavity shave in another one. And likewise, something that is called as a re-excision in one department might be called a cavity shave in the other. And so we had to just take a view on what we really wanted to label these as. And I'm not suggesting that you should necessarily change the way your surgeons might call these, but we took a stand on calling them essentially. And you can collate into your department what that specimen means. So we said a cavity shave is a small portion of tissue, I think it is, which is taken as routine from multiple radial margins at the same time as main surgery. I think some departments have protocols of taking 6 kind of cavity shaves or bed biopsies. That specimen we've called as cavity shaves. They're usually quite small, like a millimeter or so. And that's done in all specimens. The re-excision specimen, however, is is a much significantly larger portion of tissue, usually taken from a margin that is deemed as being close on specimen radiography or involved even close to a margin, etc. And this might be either an immediate re-excision, which is done at the same time as the main surgery, or a delayed re-excision. Both these specimens we've suggested are handled in a similar way. So cavity shape, you weigh it, you measure it, particularly the thickness. You embed in total in one block. If it is oriented, put the new margin face down so that if that is involved, you just say margin involved. In the way, in a cavity shape, it is not usually possible to measure the distance to the margin because you've just done it face down on the new margin. So this is a kind of schematic representation of how this is done. And any kind of, you see the ink all around, any involvement is a margin, is deemed as margin being involved. The re-excision is slightly different. They are usually larger pieces of tissue. And I think sometimes, and I'll come to that actually maybe later on, we don't recommend inking it with multiple colors like a wide local excision. There are occasional scenarios where the surgeon may have missed the tumor completely in the main wide, it's like a missed marker type scenario. And then they've gone and done a further re-excision, but that's actually the main wide local excision again. But that's an exception. That's not that common. And this is for the scenario where a re-excision is done because a certain margin is deemed to be close at the time of surgery or involved, and then they've gone back and done a re-excision. We don't think it's worth inking with multiple colors like a wide local excision. We do not suggest you do the shave approach, as in shave off the little edge of the thing and put that down. We think if it's about less than 30 millimeters, 3 centimeters, you could sample it. So that was a question that was asked a lot as well. How much should we sample? Sometimes these can be quite substantial pieces of tissue, especially with more and more kind of oncoplastic techniques, etc. They're like a few hundred grams or more sometimes. So we've said if it's less than 30 millimeters, maybe sample it all. This is just a representation of how that is done. If it is a large specimen, just be practical. We've certainly seen cases where the main tumor is blocked in 4 blocks. We've got one representative margin from all radial margins. And then this re-excision has like 16 blocks of it. Doesn't make sense, you know. So examine, go with the history. If it is particularly large, it is perfectly fine to sample alternate or every 3rd slice even. Especially if you don't see anything, if it is be guided by, is there DCIS, was there lobular carcinoma, etc. And you can actually put more than one piece of tissue in a block because you're just measuring presence of tumor or not and distance to the new margin. Again, continuing with the back to basics approach, tumor size measurement, we know that from the EQA scheme that tumor size measurement can be quite variable. This is just a case. This is from 2021 EQA circulation, but it could be from literally any EQA circulation, to be honest, where you can see all these tumors where that's the median, but you've got a wide range of what participants have measured as tumor sizes all across. So we have provided further clarity on tumor size measurement. It is important because microscopic tumor size is considered as the gold standard. And we recommend very, very strongly that this is measured in millimeters rather than centimeters, because we've previously shown in the screening program that if tumor size is measured in centimeters, people tend to round up, round down. Even with millimeters, they sometimes do. So please do not round up. You know, if it's 14, it's 14, not 15. Certainly in the NHS breast screening program, it is a relevant cut of the 15 millimeter because radiologists get measured on their small tumor pickup, if you like, at a 15 millimeter cutoff. This is a diagram of how to measure tumor sizes when there are multiple foci. We'll be aware of the 5 millimeter rule. And I think these 3 are fairly easy when there is sort of DCIS around. No DCIS around, a little bit of DCIS around, that's the whole size. DCIS on the other side, that's the whole size. I think there's sometimes confusion between these 3 scenarios. And I'll show you some examples. If the 2 main invasive foci are separate, as in more than 5 millimeters apart, but there's DCIS in the middle, use the larger tumor as the main invasive tumor size, and then the whole thing as whole tumor size. Obviously, if there's no DCIS there, just that's the invasive tumor size, that's the whole tumor size. That's a separate focus with its own invasive size and tumor size. And if the invasive and DCIS is kind of admixed amongst each other, then the whole thing becomes invasive. And if DCIS extends beyond, then that's the whole size. This is an example where these 2 foci were about 3 millimeters apart. So when invasive size is measured, we would include this focus as well in the invasive size of this big tumor here. This is another example. I apologize for the quality of the section there, but I hope it gets a point across. There are multiple invasive foci, all of which are kind of less than 5 millimeters from each other. And so when you measure invasive size and whole tumor size, you measure it across the entire, across all the foci. How to sample in multiple foci. So if you can get it across one slide or one block, do it. If not, sometimes you can have to take it in multiple blocks. You may need to link it as well. There's supposed to be a line here. In terms of linking, I'll show you a case. If they're quite distinct and quite apart, make sure to sample the tissue in between so that you can pick up things like DCIS in the middle, if there is, or other foci for that matter. This is a case in one of our cases where we had a clearly invasive focus here and an invasive focus here. But actually, and we took the whole slice, and something we do in our department, we link it with ink. So that's the blue ink there where we've linked the two slides together. We put it together, and when you look closely, there's actually DCIS here. I'll show you. There's DCIS at the blue ink, as you can see here, also further in. So in terms of measuring the tumor size, this is scenario D here, where there's two clearly separate invasive foci, but DCIS in the middle. And so that would be our invasive tumor size, and that would be the whole tumor size. In terms of extensive microcalcs, just sample adequately. We've provided again, be judicious in how much we sample. We provided a rough guide of about 1 to 2 small blocks, not mega blocks, 1 to 2 small blocks per centimeter of DCIS. That's just a rough measure. You obviously will be guided by was the microinvasive foci in the biopsy, what the radiology looks like. But we've also gone to, we've seen scenarios where people have kind of put 100 blocks through or 120 blocks through wanting to sample all the microcalcs. That I don't think is necessary, and I think probably is a bit compared to the cost benefit. If you have access to a specimen X-ray, please X-ray the mastectomy slices rather than sample 100 blocks and direct it accordingly. This is one of our cases again, who had extensive DCIS, and we knew that there was kind of these yellow blobs have moved a little bit actually. So we found invasive tumor so we tend to do this mapping like this. We found invasive tumor here, and that's all that was, but there was DCIS in all these blocks right up till here. And so the invasive tumor was about 10 millimeters, which was in this block here. And the whole tumor size was 75 millimeters, was right up to here. You can see we've measured the distances here as well. Tumor size in encapsulated papillary carcinoma, again, something that gets asked quite a bit. As we know, it's an indolent cancer treated as DCIS. If it's high nuclear grade, we have a discussion in the MDT around central lymph node procedures. And of course, if there's a conventional invasive carcinoma present, you would do a central lymph node. When present, it tends to be ductal NST. In terms of size measurement, when there's just one focus, it's quite easy. That's your invasive focus. That's your whole tumor size. If there's a dominant invasive focus on one side, that still remains a bit like the 5 millimeter rule for 2 foci. But if there are lots of invasive foci across, then the whole thing becomes the invasive size as well as the invasive tumor size as well as the whole size. In terms of mitosis, just to kind of come up to speed with the digital way of counting mitosis, we've included the table that's also in the WHO on counting mitosis based on millimeter square. There is a lot more reference to even how to identify mitosis and various bits as well. But in the interest of time, I think I'll just refer you to the document. And kind of on the last bits, how am I doing for time? Got a few more minutes there. In terms of LCIS, we know LCIS, classical LCIS is treated as a risk factor. Presence at margins does not need any further surgery. However, we've provided, again, a little more guidance on things like pleomorphic LCIS. We know pleomorphic LCIS is discohesive, just like LCIS would be, but high-grade nuclei. And pleomorphism, it can be ER negative, HER2 positive. That's a good kind of clue. If you see something that looks like LCIS is pleomorphic, HER2 positive, and obviously you could use immunohistochemistry like E-cadherin or beta-catenin to kind of help in these kind of situations particularly. Having said that, these are treated as treated similar to DCIS. So if you, I guess, occasionally missed one, it probably treatment-wise, doesn't make a significant difference in that sense. I think the key thing we've explicitly stated that I'm not sure whether it was stated in the previous version, that included in the measurement of whole tumor size like you would with DCIS. Florid LCIS, on the other hand, whereas pleomorphic had nuclear pleomorphism, florid LCIS has cytology similar to classic LCIS, your type 1, type 2 nuclear, that kind of thing. What is typical is this marked expansion of acinine ducts with literally no intervening stroma, 40 to 50 cells across. We still, because they're not that common, I think knowledge about behavior is still relatively unknown. But if a lumpectomy is being done, please try and achieve a clear margin. That's the recommendation of and certainly in my MDT we would treat it sort of more closer to pleomorphic LCIS than to classical LCIS. I'll just hand over to Sarah in a second, just to kind of little plug for the Association of Breast Pathology. For those of you who aren't members of the association, I encourage you to join. Just Google Association of Breast Pathology. We're quite a vibrant, relatively young society, 8 years old or so. We have very, very good chats on all things breast. So please consider joining. Thank you. Over to you, Sarah.
Thank you, Rahul. Let me do my sharing thing. As Rahul has said, and I just want to reiterate, this is not just Rahul and my work. This is a work of a whole lot of other people who put a whole lot of effort into it and have done various different sections. And some of the things I'm talking about now are actually sections done by other people. I agree with them, but I just want to give them the kudos. I'm going to start off in a slightly weird order talking about estrogen receptor and HER2 receptor. There's not an enormous amount new in there. Obviously, no change. You should test ER and HER2 on all invasive breast cancers on the cause. The data showing that causal equivalence to excisions is pretty robust, and there is not very much change. So there's no need to repeat on all of these cases. You should test on recurrent tumours if you're getting a core biopsy of them, and metastatic biopsies if you have a core of those. I think it's a bit clearer now about when you need to retest on multiple cores. I know that some people will have multiple cores from different satellites of different tumours, and they will test ER and HER2 on all of these. If you think that these are all satellites and all the different cancers look the same, there's no need to do that. You may wish to do 1 or 2, but if you've got 9 cores from different areas or different satellites in the breast, as I know some people do get, you don't need to do HER2 on all of those or ER. You will want to test separate synchronous primaries if they look different or if there's any doubt. We couldn't reach a consensus, and there isn't really a consensus on whether you should repeat ER and HER2 post-neoadjuvant treatment. There are some members of the group and some people very firmly believe that you should, but that is not in the guidelines and it's not mandatory. The cutoff for HER2 remains remains the same, based on the percentage nuclear reactivity, and 1% or more remains the defined cut point. There is a new category, which is probably the biggest change in the ER story, in that cases with 1 to 10% nuclear ER reactivity are now recognized to show molecular heterogeneity and, in general, a more biological and indeed clinical behavior to tumours that are ER negative. The benefit of endocrine therapy for these is uncertain, and in some places, these patients with less than 10% ER positivity, which will still be defined as ER positive but ER low, will receive adjuvant endocrine therapy. In many places, the oncologists are beginning to say, well, no, we need to give adjuvant chemotherapy for these patients. There is evidence that actually this 10% cutoff is better for defining ER negativity and identifying triple negative, as it were, cancers to test for genetic mutations in BRCA1 and BRCA2. So we've got this category now that you should be reporting, which is ER low, which is 1 to 10% of cells, and your clinicians may well manage those differently. As previously, your report should include the percentage of positive nuclei, either absolute, estimated, there is no expectation that you will count these, or in 10% bands, along with the average nuclear intensity. You may wish to just give the ORBIT or the histochemical score, and that is fine as well. The other recommendation is that if your cancer is negative or weakly positive, you should make a comment about the internal control or the on-site control if there isn't any internal control, just to prove that you've thought about the QC and QA. One of the thornier issues that we debated, one could add ad nauseum, was whether we should have progesterone receptor in the RC path data set. We kept going round and round in circles a little bit with this. The ASCO-CAP guideline notes that there isn't any difference in degree of benefit from endocrine treatments according to progesterone receptor status. So if your tumour is ER positive, it will or won't respond regardless of whether it's PR positive or PGR negative. So actually only progesterone receptor is used, should be used as a decision making for whether the patient's going to benefit from endocrine adjuvant therapy. So there is this view that actually it's of limited clinical value. It is, however, quite useful prognostically if you believe that that's of value for an individual patient. So patients whose tumours are ER positive and PR negative tend to fare less well than those tumours, women with tumours that are ER positive, PR positive. The other argument that people brought up in our discussions was the quality assurance element of progesterone receptor, because you may or may not believe that ER negative, PR positive tumours exist, but at the very least they're rare. And so if you do have an ER negative, PR positive tumour, what you should do if you're doing PR is look at your ER and make sure that the quality control and the quality assurance of that is right. So ASCO-CAP and NICE do recommend PR as assessed in all invasive cancers. It could be considered good practice, but it's not mandatory because of the lack of clinical value. So we haven't included it as a mandatory item. You may or may not be doing it for the reasons that I've outlined. As an aside, it has not changed that you shouldn't be using the biomarkers from the multi-gene assays for clinical management. I'm not going to talk an awful lot about HER2 because really the guidelines, which are 2004, really relate to the update on HER2 guidelines, which were 2003. The difference in those, you will remember, is that we do have this category of HER2 low. We did anticipate it, that trastuzumab deruxtecan would be approved by NICE. It was not, but it is available in, for example, Scotland. So it's just an English thing that we cannot use, that clinicians can't prescribe it. So we do recommend, in anticipation that it might happen in the future, that you report your immuno as 0 or 1, not just negative, and then 2+ and 3+. You will also remember that in the guidelines, there is some gap filling in for where you might record unusual cases that have different and odd percentages of incomplete and complete membrane staining of different intensities. That's really not any difference in the guidelines. For HER2 retesting on the excision, there is a recommendation that you should retest on the excision if the staining is heterogeneous with focal 3+ positivity. What is not entirely clear, and I think is a debatable issue, is whether you should retest cases with a borderline negative-ish result, i.e. the ratio between 1.8 and 1.99. In one area in this document, and I apologize for this, it does say you should repeat on the surgical excision specimen, but that's what one area says, and in another area, it is less clear. And I think this is probably the reason for that. So in another area, the text says, well, this is what you should do. You should count more cells, optimally a minimum of 60, ideally with a second observer. And if you can't increase that number of cells, you should repeat on the excision. This is just the general rule of thumb. But the 1.8 to 1.9 is reported as borderline but not amplified, and in that specimen is regarded as HER2 negative. The reason for that being that if you do count more cells, you may well get a different chance, just the other side of the cut point, by chance alone. So the bottom line is, if you have got enough cells and you are happy with your ISH results, you can report the case as HER2 negative. But in essence, I think that's difficult. There is a recent paper by the Nottingham group where they looked at this, and there is a small percentage of these cases with borderline results that will turn out to be 3+ on the excision somewhere. And I must admit, despite all of this, I do tend to repeat them on the excision, and we can argue that case and discuss that case. I'll be interested to know what other people are doing. Obviously, you need to audit should be looking at your overall positivity rate. Make sure your sample size is accurate, though. Overall, you would expect about 81% of cases to be ER positive, and somewhere between 13 and 15% of cases to be HER2 positive. That will depend on whether you're getting a lot of screening cases or on your population. So you have to think more widely about that. You should be doing an audit of HER2 turnaround, and I'm sure those of you will all know that that's the biggest moan in general from the oncologists, that our HER2 results take too long to turn around. There is a new section on male breast lesions. It's short, and basically the bottom line is that all female breast lesions, including those that you think of as lobular, like ALH, LCIS, columnar cell change, have been reported in men. Gynecomastia is obviously the most common benign condition. And I just wanted to remind you of one thing, which is that you get this different pattern of basal cytokeratin positivity. I'm sorry, I took that from the book, the guidelines, and it's not well in focus. But you see this tri-layer of inner and outer basal cytokeratin positivity, and an inner layer which is luminal ER positive. So it does kind of mimic pagetoid spread by lobular neoplasia. So you do just need to remember that that's something that you see. Male breast cancers are rare but increasing in incidence, just like female breast cancer. They're mostly retroareolar. There is a link with BRCA2, so maybe you need to think about mentioning genetic referral in the MDTM. But the specimen handling, sampling, and reporting is exactly as for female breast cancer. DCS is rare. The most common, as in female breast cancer, is no special type, and invasive lobular is unsurprisingly very rare. What is interesting, and I don't know the reason for it, is that papillary lesions are more common as a percentage of lesions than in the female breast. And that includes all the spectrum from papillomas, papillary DCIS and papillary carcinoma in situ, encapsulated papillary, and so forth. Don't know why. Male breast cancer is very often ER positive, so even more than that 80% that you see in female breast cancer. Typically PR positive, androgen receptor positive, but HER2 negative, just like female breast cancer. The thing, of course, that one would consider is whether it's a metastasis to the breast. And you will all know that PSA can be positive in male breast cancer, primary breast cancer. And there is some data to suggest that GATA3 is less frequently positive, but that's not universally reported. And so I think potentially a bit of a pinch of salt of that. Some series suggest a poor outcome in male breast cancer, but not universally. So I think that's another one that you have to kind of put on ice a little bit. Very briefly, for the last couple of minutes, I want to talk about histological types and how that has changed a little bit in this updated guidelines. As Rahul said, that's in line with the WHO 2019 and ICCR and all the other sort of big international data sets. You will know that in the 2019 WHO document, these various types shown in red boxes on the right, which in the previous WHO book have been subsumed into the invasive breast cancer of no special type. And that includes invasive medullary carcinoma. One component that actually I think we emphasize more in these guidelines than they do in the WHO is the use of this mixed category. As you all know, it is very common. They are typically defined areas. The special type is less than 90%, but more than 10%. But if you have less than 10%, you should mention that other type, but record it overall as no special type. You should record all the elements. The WHO book says ideally the overall percentage of each special subtype. I'm not sure that's terribly clinically useful. And grade, as you know, is based on the overall percentage of tubules or acini. the worst pleomorphism if it's a distinct area, and the highest mitotic count. And this is just an example of a mixed invasive classical lobulate you can see here, and no special type on the left. And in the bottom right here, you can see that it's clearly the NST bit is large pleomorphic cells, 3 for pleomorphism, but there is some tubule formation, so it's 2 for tubule formation, and it's 2 for pleomorphism. It's not, well, you give the separate components. You don't call it 232 and 321 for the lobular. You take the overall bits and the worst of some components. Medullary carcinoma as a standalone entity has gone. You will know the features, the syncytial sheets and the pushing margin, and the lymphoplasmacytic infiltrate. The guideline is now that you report it as invasive breast cancer, no special type with a medullary pattern, or you can report it as no special type with lots of TILs. Couple of new types that I'm just going to very briefly mention. Mucinous cystadenocarcinoma appears in there. It looks like the ovarian or the pancreatobiliary forms. You've got the cystic structures, basally situated nuclei, columnar cells with papillary formations and tufts, usually triple negative. And obviously, again, you will want to confirm that it's not a metastasis from somewhere else. I'm lucky that I've got a gynae pathologist, Sophie Lane, who also reports breasts. So, of course, we would stick any of these under her nose, but they are vanishingly rare. You will know more about tall cell carcinoma with reverse polarity. It's rare, but not quite as vanishingly rare as mucinous cystadenocarcinoma. On low power, it looks like a papillary lesion to my eye, at least. You have these nests in dense fibrous stroma. The cells are tall and columnar, blandish nuclei, no myepithelial cells around the outside. And it's another one of these more indolent triple negative breast cancers. And it's got a typical hotspot mutation if you so wish to do it. I must admit, I never have, because it's a fairly classical appearance. Here's another case on higher power. You can see that you've got these papillary structures, no myepithelial layer around the outside. And if you are a bit stuck, the bingo eureka moment is when you see this, and you can see this reverse polarity of the tumor cells, which the cytoplasm is on the outside and the nuclei are on the inside. Solid papillary carcinoma causes people difficulty because you don't always have a myepithelial layer around the outside, and you may have to hunt for the fibrovascular cause, but these are these well-defined nodules of usually intermediate cell size. You can see invasion in it, but you have this solid papillary carcinoma in situ, and then you have these irregular features of tumor cells associated with it, just like, as Rahul has said, you can do with the encapsulated form. Invasive solid papillary carcinoma is different to solid papillary carcinoma with invasion, and this is where you sigh. But actually, the invasive solid papillary carcinoma doesn't have any of those rounded solid papillary carcinoma in situ elements, and they all look irregular, scattered jigsaw-like pattern. So here's solid papillary carcinoma. I must admit, I tend to put in situ in association with this, even if there isn't a myepithelial layer around the outside. Here's one associated with mucinous carcinoma, and here's one associated with no special type carcinoma. And here's an invasive solid papillary carcinoma. You've got these solid clumps. They do look like they've got sort of fibrovascular cores in them, but they don't have these well-defined rounded outlines. They've got much more of an irregular, jagged shape, and there's not a myepithelial cell in sight. I must admit, I suspect that I have in the past, and probably still will, have just called that no special type. And there's no known clinical difference to that. Finally, the other thing that we mentioned, neuroendocrine lesions, because you'll know that the 2019 book has a separate category for these. Some degree of neuroendocrine differentiation is very common in no special type, and particularly in mucinous solid papillary carcinoma. There's no clinical relevance that we know of, so you don't need to routinely do neuroendocrine markers other than potentially for your own interest. But if you have cancers that have a more than 90% neuroendocrine pattern, they're classified as neuroendocrine tumor or neuroendocrine carcinoma. And the neuroendocrine tumor is a thing that looks like a carcinoid. And of course, you would want to distinguish it from metastatic carcinoid. But you've got these usually rounded, nests and trabeculae, usually moderately sized cells with neuroendocrine morphology, whether that's rosettes or granular cytoplasm or spindle cell areas. They are uniformly positive for neuroendocrine markers. And one of the useful things that you need to look for is whether it's uniformly ER positive, which the breast neuroendocrine tumors usually are. Neuroendocrine carcinoma is very rare, difficult because you'll obviously need to distinguish it from metastatic small cell carcinoma of the lung, which can be problematic, but it shows the same features in essence. You sometimes do see DCIS. Large cell neuroendocrine carcinoma is even rarer. And again, it's one of those ones I think I think I probably have missed. I think the last one, and I've only seen one or two of these, I thought, oh, it looked like pleomorphic globular, because you do have this discohesion, large cells, perhaps rather more pleomorphism than you'd see in pleomorphic lobular carcinoma. And when you think of it, you do the chromogranule saprophysin, you will then make the right diagnosis. But they are vanishingly rare, and this is sort of little small print stuff, just in the guidelines to remind you to do it. And to remind you, those pathologists, we love pigeonholing. And I'll stop there, and hopefully we're roughly to time and take some questions.
Yeah, thank you very much indeed, both of you. That was fascinating, and a really huge amount of stuff to cover in a short time. And so thank you for the succinct and very clear presentations, and lovely pictures too, which is great. So thank you very much for that. Number of themes, quite a lot of questions. Before we come to the specific questions, there's a few references made to the college points system in the questions. I just pick that one up, if I may, briefly, and to say that the college, the last version, as you know, came out in 2018. It has been a source of a lot of endeavour to try to produce a new set of guidelines around the points process. That's still in hand. But it will be happening. Part of this is around the context within which we use them as the wider workload and work environment that we need to think about, which it reminds me to mention that the point system is guidance, and that the local determination can be used very effectively in sorting out discrepancies. And so when we see changes in practice, as we have done in the last 7 years, it's not unreasonable to change the way in which points are allocated. And I think that's something we can all do locally in the meantime. It does produce a bit of disparity, but I think that's probably better than doing nothing about it at all, because it is necessary to fit in with what's happening locally around about local practices. So just in mention that in passing. And carry on from there. So the first of the themes that have come up are around measurements. You'll not be surprised, Rahul, there's a lot about measurements. So distances between deposits of LCIS and DCIS, invasive tumours, how big do we call the tumour in terms of all of these pieces? And there were some pictures you showed us that. And then also distance and shaves from edges. So there are all these kind of measurement questions that are coming up. Have you any comments on those in general, or do you want to go to specifics?
No, I can make some general comments and also be more specific. So there are comments on the specimen types, we have called them, haven't we? So I think the point we're making is that in your department, what we've called cavity shave, your cavity shave might actually be a re-excision. You know, how do we embed these? It's you extrapolate to what happens in your department. And so if it is what we've called cavity shave, these are really tiny pieces of tissue. So it is not possible to slice them perpendicularly. So therefore, just put the new margin face down, and it goes as involved or not. The re-excision is different, where I agree, you need a distance to the new margin, because these are more substantial specimens. Slice perpendicularly, and then ink the new margin. And you can then actually measure the distance to the new margin, and also make a judgment on whether it's in continuity with the original tumor or not, in terms of tumor size measurements or whole tumor size measurements. So that's one thing about cavity shave versus re-excision. Because the cavity shave, as we've called it, it's not possible to slice transversely. They're very, very kind of small pieces of tissue. in terms of measuring, I skim read through some of the questions, so I'm going to try and address them in a way. If you've got an invasive tumor and DCIS even more than 5 millimeters away, I would just take the whole thing as whole tumor size. We know DCIS is a unifocal process, so include them in your measurements of, even if the DCIS is substantially away from the main kind of tumor, what it looks like. By all means, use free text. And I think one of the things which I think I'd suggest is please use free text to explain your working. If it's a tricky case, somebody talked about how do you record a block key if you're mapping biopsies. It's very difficult to, but we tend to say things like A4 taken from slice 6, 10 millimeters away from the main tumor, A16, 75 millimeters away from the main tumor, things like that. And you can explain that when you're doing a tumor size measurement. I think that's kind of covered. Is there anything I'm not covered specifically, Peter? Do you think that,
Well, it's, for example, does florid LCIS beyond invasion, the invasive, increase the WTS?
That's probably the most difficult question, actually, in that I will mention it, but not measure it. I don't know, Sarah, do you have a view?
Yeah, I'll include it in the whole tumor size.
You will include, okay, that's fair enough.
I mean, basically, I would manage it
like pleomorphic
LCIS.
Yeah, fair enough. I think that's reasonable as well.
But, it's difficult because we don't have a lot of clinical information
evidence.
on florid LCIS.
We don't have the evidence to do either way, but but certainly, like I said, if it's at a margin or close to a clinically relevant margin, as per your guidelines, most definitely mention it and consider re-excision.
Yeah, most places do re-excision.
What else will do it now? That's right.
It's a bit of an evidence-free zone, I'm afraid, at the moment.
Because they're not that common.
Oh.
Talking of evidence-free zones, there's a couple of comments about surgeons in these questions, and so there's an issue about how you manage your surgeons and terminology. Some surgeons like to do things the way they like to do them, and there's stuff about orientating re-excisions and others about terminology. How do you educate your surgeons? I think it's a challenge that we all have around about particularly new classifications and new guidance.
So what if they want a good quality report? They've got to work with us, haven't they? And we are hopefully they know we're all on the same side. We're not kind of adversarial colleagues in a way. But in terms of doing the wide local way of doing re-excision specimens, it just feels like a lot of work for not very much benefit. So, if you think that's what they want you to do, audit your internal work and say, we've taken 16 blocks, so we could have taken 4 and the information hasn't changed over, 25 reports or whatever. I think just do something like that internally and show your surgeons. We are lucky we work with a group of surgeons who do liaise with us and listen to us because we shout at them if they don't know a joke. But I think that's the only way to change practice, because I think it's a lot of work, especially if you're going to do 4 routine re-excisions in every specimen. Some centers do that, they do a main thing and then they do re-excisions, not bed biopsies. And then if you're going to orientate each of them, you're suddenly going back to the workload points, they count as potentially 5 wide local excisions. You know what I mean? Completely not value for money in terms of resources or anything really.
I think the bottom line, I can see this question from Narendra. I think the answer to that is potentially, if you've got the time or you've got a useful trainee, do some audit. Yeah. So we did this, we painted it, and this is how often it actually made any difference to clinical decision making in our hands. They will quote you papers going, oh, cavity shaves are brilliant, and you'll go, yeah, but the cavity shaves in that paper range from 20 grams to 2 grams. So they'll quote you lots of papers with different things. So I'm afraid the answer probably is to get some data of your own and go, look, this in our hands, this is how often it made a difference. So we're not doing it.
But I think a good message is stand up for what we know. Excellent. Just to change the topic slightly, there's quite a few questions around immunocytochemistry, for example. One of them that's come up a couple of times is, should we repeat hormone receptors, having done them on core, should we repeat them on resection specimens?
No, not as routine. I mean, I didn't show you the list, but there is a list of kind of 5 or 6 situations where you may want to do it if the tumor looks different, if you've got another area of tumor, you've got an area of mucinous that you didn't have. But in general, you don't need to. There's quite good evidence now that in 99% of cases, there's complete concordance between the excision and the core and the excision.
Yeah.
It was a question mark. I think in the States at one point they were saying you should repeat them if they're negative. I think if you've got good internal control, the tumour looks like it's a tumour that should be ER negative. Ideally, you're right, if you've got either internal control or on-slide control, I wouldn't necessarily repeat it, no. In fact, I wouldn't repeat it, let's be straightforward, I wouldn't.
Yeah, okay, thank you. A couple of questions about lobular carcinoma, and what's your guidance for ECAD-adherent positive lobular carcinoma? And secondly, do you use ECAD and P120 to confirm the diagnosis of lobular carcinoma, or do you rely only on morphology?
I know what Sarah thinks. I'll let her take that one.
Rahul's laughing because he knows, I think, which is, no, I don't do ECAD. If it looks like a duck and it quacks like a duck, I'll call it a lobular carcinoma. There are cases when you've got in situ disease that you're not sure what it is, or you've got something that is, you know, a bit kind of NST. Rosemary Millis used to call them blobulars. And in those instances, I would do. We haven't got P120 catenin, so I would, in those situations, do equatorian and beta-catenin, because the beta-catenin loses its membrane and becomes cytoplasmic. But I don't do it as routine, and I will quite happily accept something as an equatorian positive lobular carcinoma if it looks on H&E just like a lobular carcinoma. Because,
but you wouldn't know because you wouldn't have done it.
But my argument, I wouldn't know because we wouldn't have done it. My argument would be that all the historical data on how lobular carcinoma behaves is not based on equatorian positivity, negativity. So, you know, the stuff about metastasizing differently and nodal disease is all based on H&E.
Okay, just like to change again and talk this time about tumour size, and particularly with relation to neoadjuvant chemotherapy cases. How do we assess the size of tumour in these cases?
So can I go first, just in terms of what we've said in the guidance? We've said in the guidance, we haven't, because the most evidence out there is for residual cancer burden, you know, the MD Anderson RCB. And so in the guidance, we've said, if you're going to use one, use that one. And I think there's increasing evidence that oncologists may determine treatment based on RCB, but that's only just kind of coming through, I think. Somebody will be. So we've not gone saying you must do it, because again, if you do it if your oncologist want it, and if you're going to do some kind of scoring, use the RCB. Otherwise, but please give an indication of a measure of response. You know, even if it is kind of, you know, there's 70% reduction of tumor or tumor bed is seen and that kind of stuff. So we have said, give an estimate of response, broadly speaking. You could do RCB, but in the guidelines, we haven't said it's mandatory. Just to put it, ICCR and others have kind of included it in their kind of mandatory list. And so therefore, just to kind of put that disclaimer around, I don't use it. I ask my oncologist all the time, you know, do you want me to do it? And they say, we're not going to do any different. So I just don't think we need to kind of, in our department, in your setting, it might be different. Well, let's Sarah answer a more specific RCB type question.
No, I agree. And we do report residual cancer burden. So we'll give dimension in the maximum dimension of the invasive bit, not the tumor bed. The tumor bed is a term that I tend to try and avoid, because some people use that to mean the residual invasive disease, and some people use it as where the tumor was.
Footprint, yeah. And
But
actually on that, there's a Manuel's question as well, who's a colleague of mine, so that's I've seen it anyway, which is about how do you measure tumor size for NPI, etc., TNM, if the largest remaining invasive tumor focus, based on the largest focus, or if it's a dispersed kind of scattered tumor cells, do you just go with the largest focus, or do you take the whole scattering across the larger, you know?
If it was originally one thing, I'd count it as one thing.
Okay. Yeah, agree.
There's also a question here which is slightly different, and it's about sentinel lymph nodes. What's your opinion on levels in cytokeratins and sentinel lymph nodes?
We don't do them. I think it's a lot of
Don't
work.
do any?
No, not routinely, I mean.
We do 3 levels routinely. We don't do immuno routinely.
We used to, and then we gave it up basically because we didn't see the pickup rate change. We've done an audit in our department anyway.
Fine. I mean, I think it depends how good your first level is, which is kind of a bad issue rather than anything else. We don't do immuno, but it will save you time because it'll pick up small deposits. So it's a sort of, you know, time of the lab, time of the pathologist benefit. I think most places do 3 levels, but most places don't do immunohistochemistry. In the guideline, we just say 1 good H&E is sufficient. So if you want to go above, beyond, fine.
It is a difficult one, I think, because there are so many different protocols around how you handle sentinel nodes for different tumours. It would be nice if we could, for the labs, it's really difficult to know what to do next and to satisfy all pathologists. So I think it's something that's a relevant thing for someone perhaps to take up as a separate guideline as to how we unify the idea of these specimens.
What's happening in breast particularly, these are quite heavily investigated women anyway. Radiology is getting really good. So, the pre-op pickup is fairly reasonable of axillary lymph node involvement. And one of the things, once micromets, isolated tumor cells are always treated as node negative. Increasingly, micromets are now treated as node negative. And arguably, node positive tumors also now being treated as node, kind of not doing further things. And so the relevance of absolutely, my practical, pragmatic view is absolutely going to town to find that, micrometastasis in a breast scenario, melanoma might be different. I just don't know, they might, or gynae tumors might be different. But in breast, it's a very well-established and robust kind of evidence around axillary node involvement. So I personally don't see the point of going absolutely to find the 3 cells or 5 cells that we might find.
I think that's true, yeah.
We're really just almost out of time. So I think there are so many questions in here that are detailed questions, and thank you all participants for coming with so many questions. That it's made our lives much easier here, being able to have so much discourse. So thank you all for that. I think we've time for one quick question at the end, which is really around the term ductal carcinoma with lobular features. How do we actually address these? It seems to have fallen out of favour, the questioner suggests. But are they multifocal tumours? How do we deal with them? Given what the ICC will be in these cases, what's the best way of dealing with these?
Do you have a view, Sarah?
Yeah, I'll go with that. I think they do behave in a slightly hybrid fashion. Long time ago, when I was a baby pathologist in Nottingham, we did look at patients who developed metastases and then worked backward and looked at the primary. And there were things in there that were no special type ductal, but actually did have lobular features, and they did behave metastatic wise a bit more like lobulars. So I think there is this kind of, a group that we have to fit, we fit pigeonhole, we fit into one, NST or lobular. But I think there are these ones that have these trabeculae and sort of look a little bit lobular. And they're the ones you probably do end up doing a Guderian on, and it's positive, and then you call it lobular. I must admit, you tend to write a descriptive bit somewhere in your report saying, but there's a single pearl pattern somewhere. And I think they do behave a little bit differently, but I'm not sure that we've quite got a handle on how exactly to define them.
Yeah, that's great. Thank you. I mean, it's always classifications are fantastic, but then you've got the patients who haven't read the classification, which really upsets the apple cart.
Absolutely.
Well, I'm sorry, but I think that's all we've time for today. So just to tell everybody that the recording of this webinar will be available on the college website within a few days once it's been tidied up, and it'll be there for everybody to have a look at. So it'll be a resource that's available for everyone. And if your colleagues haven't been able to see it today, they can go back and look at it then. The professional guidelines team at the college will be sending you out a short questionnaire for feedback, and we'd love to hear what you have to say about today's webinar. So thank you both to Sarah and Rahul for their presentation today and for sharing their expertise with us, and again for all the work that goes into the preparation of these guidelines, which you can't really underestimate. Also like to thank our colleagues in the Association of Breast Pathology for participating in this webinar and for the membership and its contribution to the writing of the guidelines. Members should be aware that the next webinar in this series is the 6th of May, fortnight from today, or is it a week? It's a week today, and we'll cover the latest guidelines on histopathological reporting of carcinomas and mucinous neoplasms of the appendix. You can find out more information on all of the upcoming webinars related to this programme on the webinar pages on the college website. In the meantime, Thank you all very much and have a great day.